It's the 27th of September 2020, and we stay with the good news. 5,140 people have died because of COVID-19 over the past 6 months in Delhi, which gives us an infection fatality rate of 0.079%, which is extremely low, nothing to be alarmed about. And I don't think there is any cause for concern about a second peak. I don't think a second peak is coming because we have data from August that almost 30% of Delhiites have developed antibodies against the Chinese virus, and another survey is ongoing. We should have the results very soon, and one presumes that maybe there would be a rise in the number of people having antibodies, or maybe the numbers would remain the same. But what is important to keep in mind, and bearing in mind that we have data from Singapore and we have data from Sweden, that for every one person who develops antibodies, there are 2 people who develop T cells. And T cells are as effective as antibodies in combating the Chinese virus, and T cells also will carry on doing the work years down the line. And that may be the reason why the infection rate in India is low and why the fatality in India is so low. Because remember, the fatality rate in India is still 66 per million as opposed to more than 600 per million in the US and in Brazil. So that is something to keep us, feeling nice and feeling good. Every death I keep mentioning is a very, very sad and somber event. But as a doctor and as a clinician, I have to give you the right perspective. Now, the number of deaths in children across the world is very, very low. In fact, the Washington Post reported a few days back that children who have died, that means children, we talk about teenagers and children younger in age than that, are very low. I won't give you the figure. I will give you the figures from 2016 first. These were published in the New England Journal of Medicine. They came from government data from the United States of America. And this showed that in 2016, around 20,000 children, that means people below the age of 24 years, died in that 1 year. Of these 20,000 people who died, 12,000 were because of injuries. Of these 12,000, almost 4,000 were because of car accidents. 3,000 were because of homicides, or maybe 2,000 because of homicides, and 1,000 were because of suicidal gunshots. 1,000 were because of congenital diseases. Almost 1,000 young people died because of drowning. About 250 died because of burns. 250 died because of respiratory diseases. 550 died because of heart diseases. So the numbers are huge. Again, I will repeat that about 1,000 children died because of drowning and 1,000 children died because of congenital diseases. More than 2,000 children died because of homicide/murders, and almost 3,000 to 4,000 children died because of car accidents. Now, what is the number which is provided by the CDC and published by the Washington Post a few days back? This number is 100. I repeat that of the 2 lakh people who have died in the US, 200,000 people have died because of COVID-19 in the US. Only 100 children and teenagers have died because of COVID-19. Now, which makes scientists and clinicians and physicians wonder as to why children are so less infected, and if infected, why the infection is so mild, and why is the mortality so low in children. Of course, this is a blessing for our young ones. It is a blessing for people below the age of 20 years. And in India, we have almost 50 percent of the population which should be below the age of 24 years, and that may also account for the low fatality rate in India. Now, there is a very interesting paper which has been published recently, which is showing, and this has actually compared 60 children below the age of 20 years and compared that to 60 adults who were admitted with COVID-19. So we have a comparison of 60 children of COVID-19 compared to 60 adults with COVID-19 who are hospitalized, and they showed that there was a significant reduction in the seriousness of the illness in children, in the need for intubation and mortality. About 5 children required a ventilator as opposed to 22 adults, and about 2 children died because of COVID-19 as opposed to 17 who died in adults. So therefore we find a significant reduction in mortality and the need for intubation in children as compared to adults. But what was the specific feature which was associated with children not dying nor requiring ventilation? It was not the presence of T cells, it was not the presence of less ACE2 enzymes or the ACE2 protein, the receptor protein. It was in fact an increased number of interferon gamma and interleukin 17. Now, these two proteins were found in children. These two proteins were not present in adults, or if they were present to a very small extent. Now, the fact is that these two proteins are very, very important operators for the innate immunity or for the first line of defense. These are the first line response or the team responders to the coronavirus or the Chinese virus. So therefore, the researchers have concluded that possibly, or rather probably, children are less affected by the Chinese virus because of these two proteins, interferon gamma and interleukin 17. And it is not because that children have suffered common colds, because that is also present in adults. Now, that brings us to the enzyme or the protein which is interferon gamma, or rather interferons. Now, remember, some months back, in fact in the month of May, I had talked about a randomized trial employing interferon which was published from Hong Kong in the Lancet. This compared a combination therapy of interferon with lopinavir and ritonavir and ribavirin, compared this only to lopinavir and ritonavir, and showed that virus shedding was reduced in the group given interferon. In the patients of COVID-19 who received interferon, virus shedding was significantly reduced, and by almost 4 to 5 days. After that, not much was heard about interferon, but again now there are some studies which are showing that patients who have COVID-19 have lower levels of interferon. So therefore, a case is being made that if interferon is given early in the onset of infection, then there may be quicker recovery. Because right now we have just 2 drugs which have been found to be effective. Both are, one of them of course has been because of the recovery trial, that is steroids. We have a meta-analysis of 1,700 patients from randomized trials which have been published by the WHO, also published in JAMA, which has shown that dexamethasone in critical patients or serious patients of COVID-19 reduces mortality by 35%. Prednisolone, methylprednisolone, reduces mortality by 10%, and hydrocortisone reduces mortality in critical patients of COVID-19 by almost 30%. So now the protocol more or less is that if a patient is hospitalized, we give them a steroid, and if a patient is hospitalized because of the remdesivir randomized trials, which have shown that though remdesivir does not reduce mortality, it does reduce recovery time, it shortens the recovery time significantly, and therefore in hospitalized patients we give remdesivir and if the patient becomes critical, we give them steroids. Steroids are not to be given in patients who do not require oxygen. So we have two medicines which are to be used in patients who are hospitalized. So what do we do with patients who are not hospitalized? So therefore, now we have another modality, and this is called monoclonal antibodies. What are monoclonal antibodies? Monoclonal antibodies, unlike the antibodies produced by a vaccine or produced by natural disease, is a specific antibody which attacks a specific part of the antigen. So the monoclonal antibodies, please remember, are very expensive to manufacture and in fact difficult to manufacture, but have been found effective. And this is by a study done by Eli Lilly, which included about 250 or almost 400 patients of COVID-19, and have shown, but these were patients who were not hospitalized. These are patients who have come in and have come in early in their disease. The number of people who were hospitalized, who were given the monoclonal antibody made by Eli Lilly, the number of patients who were hospitalized was just 1.7% as opposed to 6% of people who were not given the antibody. Now, how are antibody or monoclonal antibodies made? They were made initially in the 70s and used in the 80s for kidney rejections. They are made by, earlier, they were made by injecting an antigen into a mouse. The mouse produced the antibodies. These antibodies were combined with plasma cells. Plasma cells are like cancer cells. So now we have a hybridoma cell. We have a hybrid. We have a cell which is a combination of an antibody and a combination of plasma cell. The requirement of a plasma cell is that it can manufacture antibodies very quickly. So now we have monoclonal antibodies. We have a number of antibodies, but the researchers then pick out the monoclonal antibody, which is specific, which is a single antibody or maybe two antibodies which will attack a particular part of the bacteria or the virus. In this case, the monoclonal antibody is to attack the spike protein. In fact, all vaccines and all antibodies are designed to attack the spike protein because it is the spike protein of the Chinese virus which enables the virus to penetrate the human cell. So we have another company called Regeneron, and Regeneron has also made a monoclonal antibody which is being tested by the Oxford group in the recovery trial. Almost 2,000 patients will be given their monoclonal antibody, and the results are awaited. We should have the results in a couple of months' time. Now, if we have a monoclonal antibody which is effective against the coronavirus, this is good news, despite the fact that the monoclonal antibody may be expensive. But this would act as a passive immunity. This could not only correct or treat the disease if given earlier enough, but also may prevent the infection by the Chinese virus. So therefore, this would be particularly effective in elderly people, in nursing homes, in a house wherein a single person has been infected, to prevent the other members of the family from being infected if they are given the monoclonal antibody. And the results would be available. The clinical results have been made public by Eli Lilly, but the actual scientific data has not been revealed by them. But I presume that the scientific data would be revealed very soon. Now, I keep harping on dexamethasone and remdesivir and now on monoclonal antibodies because I want to warn you that the vaccine is still some months away, and there is no guarantee that the vaccine will work in everyone. There is no guarantee that there will be no long-term adverse effects of this vaccine. That has to be kept in mind, despite the fact that thousands of patients are being treated, not patients, but volunteers or participants have been given these vaccines. Moderna has 30,000 participants in its phase 3 trial. AstraZeneca has 35,000 participants. I think Pfizer has 44,000 participants, and Johnson & Johnson is going to recruit 60,000 participants. So we'll have a number of vaccines available to us in a few months' time, and we may also have a choice. But this is tempered with the knowledge that the bar which has been set by the FDA and by other regulators is just 50% efficacy. The flu virus vaccine also has on an average 50% efficacy. And in fact, in 2017, just 3 years ago, the efficacy of the flu vaccine was only 17% in the United Kingdom, which was very, very low. So you should be prepared for a coronavirus vaccine, which may be effective in less than 50% also, but could be effective in more than 50%. Now, the other thing which we have to keep in mind about, apart from the vaccine, is vitamin D. Now, there is some data that vitamin D may prevent infections by the Chinese virus, and if people are infected, the infection may be less severe. Now, there is no randomized data. These are all observational studies, so I am still very skeptical about the vitamin D data. But remember, too high levels of vitamin D can damage the kidneys by producing kidney stones and also by making the bones weak. But I mentioned vitamin D because a recent report published in the Indian Express has reported that most, if not all, of our athletes who are being trained for the Olympics, most of them are short of vitamin D. Most of them have low vitamins D. And the reason for that is possibly either they were short of vitamin D to begin with, or because of the lockdowns, they have been barricaded and have been denied sun. Now, sun is a very important factor in making vitamin D in the skin of the human body. Now, if you are kept indoors, then two things will happen. Your vitamin D levels will fall because you are away from the sunshine. And second, you may gain weight. And again, we have already spoken that increased weight, or rather obesity, is a risk factor for the Chinese virus, for COVID-19. So back to the Indian athletes. The Indian sports people, the Indian athletes have low levels of COVID-19, but luckily the coaches and the management is tackling that by giving them vitamin D. Now, vitamin D can be given on a daily basis or once in a week, either by capsules or by a powder, and the level has to be above 30 nanograms per mil. So remember, the cutoff point for vitamin D regarding COVID-19 is being kept at 30 nanograms per mil. If your vitamin D level is below 30 nanograms per mil, then you are more vulnerable to COVID-19. 1 nanogram is 1 billionth of a gram. Now, there is a study which has been published by the University of Iran. This is an Iranian study. This has been published in the journal PLOS 1, published very recently. This had about 450 people with COVID-19, and then they divided them by their vitamin D level, and the vitamin D level, the threshold was again 30 nanograms per mil. And the researchers found that people who had a level less than 30 nanograms per mil of vitamin D had worse clinical outcomes, and also they had more mortality. In fact, in people above the age of 40 years, people who had higher levels of vitamin D, that is above 30 nanograms per mil, mortality was just 10%, as opposed to 20% in the patients who had a vitamin D level of less than 30 nanograms per mil. So I will repeat what I have said to you so far, that the fatality rate, the infection fatality rate in Delhi is extremely low. It is less than 0.1%. And we have with us, for treatment of hospitalized patients, we have remdesivir and we have steroids. For people who have yet not been hospitalized, we have two kinds of medication. One is interferon. And of course, interferon can be given also in the hospital, but it has to be given early. And also we have convalescent plasma, which must be administered within 3 days of symptom onset. We also have interferon, and we also have monoclonal antibodies. We have a study which has been reported from Eli Lilly, and this study will soon be published. This has been reported in the press, and we have a study going on in recovery, and that monoclonal antibody will be provided by Regeneron. And apart from this, we have vitamin D. There are reports, there are studies, there is no solid randomized data, but there is a suggestion that if vitamin D levels are above 30 nanograms per mil, then the infection would be less severe in people. Now, I will now make things difficult for you. I'm trying to explain to you certain numbers. Now, remember, the British have reported that the prevalence of COVID-19 in the United Kingdom is just 0.1%, which means that if we take 10,000 people, 100 people would be infected. However, they also say that the false positive rate is 0.8%, which means that if 10,000 people are infected, we may get a false positive of almost 80 people. So if 10,000 people are tested for COVID-19, 80 people would be false positive. And if 10,000 people are tested because the prevalence is 0.1%, then there would be 10 people who would be true positives. So now the press would report that the people who are infected are or positive cases are 100 of 10,000. But the actual figure would be that of these 100 people or 90 people who are considered to be case positives, the true positives would only be 10, and 80 people would be false positives. So therefore, if we are told that in Delhi 4,000 people have been found to be positives, that means they are case positives. Actually, of these 4,000 people, only 400 people are true positives, and 4,600 or 4,500 people are false positives. Now, I would again repeat this. The prevalence in a population of COVID-19, especially in England, is 0.1%, which means that in 10,000 people, the disease is actually present in only 10 people. Now, we also know that the false positive rate of the PCR test is 0.8%, which means that if 10,000 people are tested, we will have almost 80 people who are falsely classified as positive. So the press or the media would report that 90 people have been found to be infected. Of these 90 people who have been found to be infected by the PCR test, actually only 10 would be true positives and 80 would be false positives. So 10 of 80 would mean that the true positivity rate would be just about 10 or 11%. So which means that almost 88% to 90% of cases who are considered to be positives are actually false positives. So therefore, if 4,000 cases are detected in Delhi by the PCR test, and I'm not talking about the rapid antigen test, I'm talking about the RT-PCR test. If 100 people are reported to be positive, only 90%, not only, but actually 90% of them would be false positives. So if Delhi reports 4,000 cases a day of COVID-19, in actuality, only 400 of them are true positives and 860 of them are false positives. I will end by a note on the vaccine. The vaccine is still some months away. Please remember that the vaccine will not be effective in everyone. The vaccine will not be adverse events foolproof. We still have no data of the long-term adverse effects of the vaccine. And this is not a Hollywood film. This is not a Bollywood film wherein a magical vaccine appears and immediately eradicates this pandemic, removes COVID-19 virus from every human on the planet. The vaccine is not a magic bullet. It is not a silver bullet. But we don't have to be despondent. The vaccine will be a part of our ammunition. It will be also helpful. It will be in addition to the treatments we have. The treatments we have, I will elaborate. I will end by saying we have steroids, we have remdesivir, we have convalescent plasma, we have interferon, and we possibly also have vitamin D. Now, the last 3 or 4 of them, of these 5 treatments, would be quite cheap. Now, I will end this video with this, and I hope you have a good Sunday. Do enjoy your Sunday, and do not forget to press the bell icon on my channel. Thank you very much, because the more bell icons are pressed, the more likes which are delivered on my video. That gives me more inspiration and helps me to carry on with this endeavor. Thank you very much.